All right, good afternoon, everyone. Thank you for joining. Today's session is module number 7, loss, grief, and bereavement. My name is Marquetta Lipfoot, and it has been my pleasure to provide these sessions with you all. I've learned a lot as well along the way. Let me make sure I'm getting oh, there we are. I want to start today by reading a quote to you from Washington Irving. There is a sacredness in tears. They are not the mark of weakness, but of power. They speak more eloquently than 10,000 tongues. They are the messengers of overwhelming grief, of deep contrition, and of unspeakable love. That had a great impact on me. I just wanted to share that with you guys today. Here we see our objectives for today. Hopefully when we complete this module, you guys will be able to define loss and grief and bereavement and mourning, distinguish between the types of grief, talk about those tasks and factors of grief, provide interventions that may be able to facilitate normal grief, define some personal death awareness and cumulative loss, as well as identifying systems of support that the nurse or can assess in order to assist with coping. Take a quick glance today at the NCP guidelines that talk about care of the patient nearing the end of life. That domain number 7 is care of the patient. The IDT includes professionals with training in end-of-life care. That includes assessment and management of grief and bereavement. Of course, this falls into that IDT talking about approaching death with those patients and the families, being able to identify spiritual concerns that are related to death and to dying, even some beliefs about the afterlife. There's a guideline about facilitating cultural assessments and attending to the cultural aspects of care at life's end, including looking at rituals and beliefs that are related to death and dying. There's a guideline for supporting legacy building activities, including a life review, notes to families and friends, or video diary. Planning for post-death care, that includes funeral planning, as well as providing grief and bereavement support. There's a guideline that relates to treatment prior to death, that the IDT is going to provide anticipatory grief support to the family and to the caregivers, as well as during the dying process and immediately following death. The IDT is available to provide support during that dying process. And with the bereavement support is available to the family and the care team, either directly or through a referral. The IDT identifies or provides resources, including grief counseling, spiritual support, peer support, specific to the assessed needs. Prepared in advance of the patient's death, the bereavement care plan is activated after the death of the patient and addresses immediate and longer-term needs. That third domain that deals with psychological and psychiatric aspects of care, from a global standpoint, it supports patients, families, and staff that have experienced or will experience compassion fatigue or moral distress, grief, loss, and bereavement. From a screening and assessment standpoint, the IDT conducts ongoing assessment and reassessment for anticipatory grief, as well as the risk for prolonged grief disorder, starting at the diagnosis all throughout the life, the illness trajectory. And of course, for treatment, that's either directly or through referral. Patients, families, that includes parents and children that are at risk for prolonged grief disorder, are provided with services and support based on best practices. And finally, family support related to anticipatory grief, the emotional aspects of caregiving, caregiver burden, or practical needs related to caregiving. ask the question whether or not any of these scenarios sound familiar. Susan is a single mom, had one child killed in a motorcycle accident. Josh and Heather, their 21-year-old daughter, committed suicide. Martin lost a partner to a heart attack. And William, spouse of 60 years, died from complications of diabetes. Well, it says that you guys know these stories well, because, of course, your nurses, as well as other members of the team, witness loss and grief on a pretty regular basis, I would say. And, of course, many patients go through and lose their health. They experience changes in their body because of the illnesses that they have. And, of course, we see death on a regular basis, and some that are well and some that are considered a bad death or a death with difficulty. And of course, there are times when nurses experience or witness moral distress. And of course, other members of the team will experience or witness moral distress. The question is, how do we proceed with grief? I think that each individual will identify, respond to, and deal with grief differently. So the question that asks, how does one process this grief? I think that that's a very individual situation. Today, I'm in hopes of, as we better understand grief and the types of grief, that we'll be able to not only reflect the care that we provide as we are able to identify and deal with grief, but it gives us hopefully an insight to ourselves and how we deal with grief. Got a couple of definitions here. Loss is defined as the absence of a possession or a future possession, comes with the response to grief and the expression of mourning. Losses occur, they may occur before death for the patient, or as they anticipate and experience, losing their health, changing their roles or their relationships, and loss of life. That's considered anticipatory grief, and we'll talk about that a little bit more later. Of course, once a death has occurred, that survivor, they experience the loss of their loved one. And most losses trigger mourning and grief and other feelings and behaviors or reactions to that loss. Patients sometimes, think about their loss of health, their financial security, body parts, family members and survivors. Everyone experiences loss. Grief, it's the emotional response to that loss. It's individualized and personalized feelings, responses, and behaviors that we have to real or perceived or even anticipated loss. Feelings that associated with grief can't be felt directly by others, but the reactions to the grief and those behaviors may be assessed by, the nurse or the IDT team members. These feelings, of course, can include being angry, frustrated, lonely, sad, guilty, regret, and even sometimes just some peace. Oftentimes I think that grievers are considered to be all over the place emotionally, and that's so true. Bereavement provides dispensation from usual activities for a period of time. The next slide, we're going to talk about a little bit more about some bereavement, but it comes with certain rituals and obligations. And when you think about bereavement in terms of those rituals and things that we do, of course, that's planning a funeral or getting rid of or distributing the worldly possessions of a person, and, other things that sometimes are outlined during the will. Mourning, it's the outward social expression of the loss or the death. How a person outwardly expresses a loss could be dictated by their cultural norms or their customs and practices. Of course, that includes those rituals and traditions. It can also involve the process by which that bereaved person integrates that loss into moving forward into their life. Taking a look at overview of loss, grief, and bereavement. Loss, grief, and bereavement, they're experienced by everyone, the patient, the family, the nurse, and everybody experience it in their own way. We have to be able to, use and encourage family members and those that have suffered loss to express and use their own coping skills, and of course grieve and loss, and mourn with their own cultural norms or their own belief systems. We have to be able to make sure that they know that it's okay to experience that loss or that grief in the way that is comfortable for them. Sometimes past and present life experience related to grief, loss, and bereavement. Um, I've been told that America is a death denying society. Americans will deny the need to express grief and to feel pain that happens after loss. I'm fine. I'm okay. Does that sound familiar? And of course, expressing grief and experiencing the loss, that aids, that starts the healing, the psychological healing from the inside out. So, we have to be able to use an interprofessional approach. That's the social worker, the chaplain, the volunteer, the grief and the bereavement coordinators, and other team members to make sure to facilitate the patient and the survivors their grief process. Every discipline can really contribute its own unique expertise to the bereavement plan of care. Some inconvenient interruptions, that is the effects of serious illness on the patient's social well-being. So when, taking care of a patient that has a serious illness, we have to keep in mind that there are so many other issues that their disease is tearing up or disrupting. It's not just the physical body, but it also interrupts them psychologically and socially, culturally, spiritually, existentially, and financially. Um, it totally interrupts their life, the life that they have with their family. Um, it can interrupt their hopes and their aspirations, their dreams that they have for the future, whether it was looking to further their education or a promotion at work or wanting to travel or inability to be totally present. And it also can result in isolation, have feelings of not feeling well, or taking a look at those because of the physical changes that take place. Losing hair or scars or loss of body parts tend to make people want to not be around, or losing weight, or just that awkward sense of nothing fits anymore, or I have to have a wig or an assistive device, and which again that begins to make interactions with other people really, really awkward. And so that lends to socially isolation. Is it that patients seek to find meaning in illness? Or is it that they seek to find meaning in the life that's now left, in relationships, and in all that we value? We are committed to prevent suffering as much as we can, but there's so many times when patients, when they're seeking that meaning of their illness, their suffering is creating one of the greatest challenges to uncovering that meaning. Can be seen through physical and emotional or spiritual distress or anticipatory grief, and that is grieving before they even have completely had a loss, just grieving the way that things were. Patients are frequently seen broken from a physical standpoint as well as spiritually. This brokenness, of course, helps their souls, or allows their souls to cry, or to cry out and even ask that ever existential question, why? Though they may not ever get that answer, it does give them a little bit of a meaning. I did want to just say that as a nurse taking care of these patients, the role is, of course, always respect that suffering that patient and their attempts to make sense of it. Whatever that sense, making sense of that illness is, provide opportunities for telling or for them to share what they're feeling or even to share their story. It's also important that we be present and attend to these patients. If not, we kind of violate that providing supportive care to patients. When we think about serious illness, I just want to turn the corner a little bit and just talk about the idea that it has an impact on intimacy and sexuality. Because sexuality, of course, is rarely assessed in a patient with serious illness. There are different stages, and each of these stages affect different sexuality and sexual functioning. Yet rarely is sexuality considered a part of the social um, or emotional coping or a medical concern. So there again, it goes back to not really being something that people talk about or that their nursing will assess. But as those patients get sicker and they get closer to death, they get more tired, they don't have the desire. Physical symptoms may keep them from being able to traditionally express themselves as they would from a sexual standpoint. So just keeping in mind some questions that, to be able to ask, and that would be, how has your illness affected your sexuality or your intimacy? We just have to keep in mind that, the idea of intimacy goes beyond just actually being physical and sexual. Sometimes just being able to be touched at the end of life is a greater show of intimacy to a patient with serious illness. Some ways to foster that intimacy, of course, we want to always, allow privacy. Tell the partner, get in bed with their loved one. Just let them have that closeness. And of course, as much as the partner would like to be able to provide physical care, bathing the patient or putting on lotion or encouraging touch, because again, touch is one of the greatest expressions of intimacy. Here we have a young man that had a wife that suffered a asthma attack and died. Peter DeMarco, he went back and wrote a letter to the intensive care unit staff at Cambridge Hospital that took care of him. If you'll click on that link, you'll be able to see that entire story, but I do want to just read just an excerpt of this letter. He said, they, meaning the nurses, they asked me to leave the room for a moment, and when I returned, they had shifted Laura to the right side of the bed, left just enough room for me to crawl into bed with her one last time. I asked if they could give us 1 hour without one single interruption, and they nodded, closed the curtains and the doors, and shut off the lights. I nestled my body against hers. She looked so beautiful, and I told her so, stroking her hair and her face. Pulling her gown down slightly, I kissed her breast, and I laid my head on her chest, feeling it rise and fall with each breath. Her heartbeat in my ear. This was our last tender moment as a husband and a wife, and it was more natural and pure and comforting than anything that I have ever felt. Then I fell asleep. I will remember that last hour together for the rest of my life. It was a gift beyond gifts, and I have Donna and Jen to thank for it. Peter DeMarco. Like I said, when you guys get a chance, it's a very touching letter that this young man was able to experience intimacy and closeness with his wife, even on her deathbed. Here, let me see if I can get this to show.
Check-in time is 3.
It's 2:55.
I know.
A lot of people believe that you just live happily ever after, and that just is a myth.
People like ourselves, older, are hiding in nursing homes or whatever because they are scared to death.
It's incredibly common to go back into the closet again.
You just know when they don't want you there.
We've heard about homemakers going in, taking out a Bible and having the elder pray and asking for forgiveness.
And to be cured. It's not too late for you to be cured of this. They go back in the closet. She might mistreat me or abuse me.
They're so afraid of it, they are resisting any kind of medical attention.
That person was in their mid-20s during the McCarthy era.
The closet was the norm.
They could lose their job, they could lose, families.
We were sick.
Just
we were
sick
We were
people.
considered sick.
People were involuntarily hospitalized in psychiatric facilities.
Even electroshock.
The degradation of these people is so complete that their sex satisfaction come only in being tortured themselves.
I was on the route to the nut farm.
So there's a real distrust of mainstream institutions.
I would never put myself in danger.
He became much more fearful of people knowing that he was gay.
You're not leaving now, are you?
Not right now.
LGBT elders are more likely than the general population to age alone because many gay elders never had children, have not had great relationships with their families of origin. There would be a higher degree of sort of alienation and isolation.
My family was the reason I existed, and I lost them all. If they ever choose to catch up before I die, I welcome them.
LGBT aging issues are an epidemic.
There's a small and growing group of us.
We're trying to go into the existing network so they become more inclusive. One of the most common lines we get is like, we don't have any gay elders here.
If I wasn't the only person responsible for Alexander, I would have ended my life.
This is our life.
Good to see ya! Hi! We'll be there in a few years.
I'll build the stairway to paradise
with a new step every day.
We have a whole generation of people who don't know who we are. That's really sad, because you're missing out on a lot. We know a lot. We did a lot for you. You wouldn't be here if it weren't for us.
Look at how scrawny they are. Too bad I don't have an open casket.
Well, there'll be no open casket. There won't be anything, right?
If we are saying come out and be filled with pride, it's our responsibility to make sure that continues right through their last day.
So that was just an opportunity to see that there's still discrimination against lesbian, gay, bisexual, transgender folks. And it was disheartening to hear them say that some people actually will go back into the closet. They will actually die alone for fear of being ostracized or criticized. So when we think about what are the patient's basic needs at the end of life, of course, the basic needs, of course, are to be able to control their physical symptoms and to be provided shelter, being able to be assisted with elimination and being able to get help with bathing or personal hygiene, food or fluids if possible, just having someone right there with them, and even recognition of their continued existence. Listen to understand this statement. We will keep you warm and we will keep you dry. We will keep you clean. We will help you with elimination with your bowels and your bladder function. We will always offer you food and fluid. We will be with you. We'll bear witness to your pain and to your sorrows, your disappointments and your triumphs. We will listen to the stories of your life and will remember the story of your passing. It's important for us to understand how patients and their families comprehend the idea of loss. In order to better understand loss, grief, and bereavement, we have to be willing and committed to spend time with the patients and their families, hear those stories, be present, and to bear witness. Of course, we can't always fix everything, but we are always present. That is vital and it is necessary. Move on to section 2, talk about some factors that influence the grief process in survivors. There are many factors that affect the grief process, of course, and that is that personality of the survivor, their ability to cope and their patterns, history of substance abuse, their relationship to the deceased, the nature of that relationship and the age of that survivor and the deceased, and even financial arrangements. Survivor or religious, spiritual belief systems, the type of death and preparation, whether it was a sudden event, was it a long chronic illness, was it suicide, was it an accident or trauma? The survivor's ethnicity and culture, those traditions, rites, and rituals. There are many variations when you think about rituals and mourning practices in all those cultures that provide a context for the grief experience. Other factors, of course, could be, you look at whether or not there's a history of mental illness. That would be depression or suicide episodes. Are there support systems in place? Do they have other things that weigh in as stressors? And, what is their experience of history of having loss? When we think about fading away, it occurs when families realize that their sick family member is no longer just living with a serious and complex illness, but they're also dying from it. Oh, my mom's renal failure is not getting any better, and she's going to die. There are so many dimensions that both the patients and the family member go through. They don't happen step by step. They're not textbook, but they all are interrelated and they all link to each other. When we think about redefining, of course, that's a shift for the patients and their family from the way that it used to be to the way things are now. Their life and their roles are being redefined by their illness. Burdening, that's when a patient may experience that lack of purpose. They become more dependent, or they feel like, I don't want to be a burden on my family. That would be physically, financially, emotionally, socially. They just don't want to be a burden. Families don't always feel like that the care that they're given is a burden, just something that you do for a loved one. And I encourage you to encourage those family members to let the patients know that that's just what we do when we love. We show people that we love. Thinking about struggling with a paradox, they may struggle with the fact that they're living and dying at the same time. I'm living with cancer as an example, but I'm also dying from cancer. They want to live, but they know they won't live. They won't survive. Spouses, of course, they want to take care of their wife, their husband, but they also want to have a normal, as normal can be during this time. Think about contending with change. The roles change. Being able to socialize changes. Work patterns. The life that they used to have will no longer be there. And as they begin to search for meaning, sometimes those patients journey inward and they do a lot of spiritual reflection. They become more connected to those family members and friends. Those family members also find themselves searching for some meaning, or they'll just tolerate the situation. Living day to day. For those patients that find the meaning in their illness, they're better equipped to live each day with a better attitude, a better positive attitude. Family, those that look at making the best of it, they make the very best efforts to take one moment at a time and to just enjoy every bit of the time that they have with that loved one. In preparation for death, You know, patients want to leave something, they want to leave a legacy, and those family members want to meet every single need of that patient. So that's the whole idea when you think about the transitioning or fading away, to be able to take a look at these dimensions. When we talk about caregiving, the human toll that it has over lives, you know, this slide is basically intended to just to show how important that caregivers and the amount of time and effort that it takes. So, you know, most patients, they have a family caregiver that's there, and that's really an extension of the healthcare workforce. But if you take a look at that, 24/7, they're available. And a lot of families have those family members that are caregivers that are oftentimes women. They provide 37 billion hours in unpaid care per year. And of course, this is valued at about 470 billion. So just to let you know, there is taxing on caregivers, because this is not something that they do as a job. This is that human toll. This is the cost of loving and providing care for those family members. You know, just always remember to check in on that caregiver and ask them how they're doing when you see them with their family member in their home, or when you see them visiting family members at the long-term care facility. Got to make sure that we give them encouragement, and also just kind of letting them know, hey, I know this is super difficult, but you probably would want to be anywhere else. And just acknowledging what they do. You know, what you're doing for your husband is so hard, and it takes so much courage. You know, caregivers oftentimes share that while the work of caregiving is so challenging, they're grateful for it. They're happy to have had the opportunity to take this extra time and take these extra moments to provide care to their loved one. What do the family caregivers want when they're grieving? Well, they want to know that their loved ones' wishes are being honored. They want to be able to be a part of that decision making. They want to actually put hands on or get some practical help. You know, for instance, you know, ask them if they have a neighbor that's willing to come and assist with food, or going to the grocery store, or, you know, picking up meds from the pharmacy. They want to have honest conversation. They want to be heard and listened to. And so just being present is extremely important. They want their remembrance of being good and a compassionate caregiver. And of course, they want the assurance to know that they did everything that they possibly could have done for their loved one. To have a grief and bereavement program, that's a core component of a palliative care program. These components that are listed here have to be present in a grief and bereavement program. So, you know, having that interprofessional team, the assessment and the reassessment, support staff, taking a look at those grief risks, support and prompt referral, intensive support and prompt referrals, that bereavement window of 13 months after the death of that loved one, being able to provide that cultural appropriate information, respecting the developmental, cultural, and spiritual needs, being able to assess, provide resilience, cumulative loss, and grief of IDT. So I'll ask the question here, just an inner question for you. How do you and your organization address grief and bereavement? Is there a formalized program that you have in place? You know, if you think back to the slide earlier where I had those scenarios, you know, where there was a young boy killed in an accident, daughter committed suicide, grief over a partner, you know, so it makes me ask you guys the question, do you have policies and procedures in place for your institution to be able to meet the needs of those folks? Or, you know, are there ways that you can improve or expand your program? when we talk about the grief process, we'll kind of switch gears just a little bit here. You know, grief is a process and it's a response to bereavement. It starts before the patient even dies, for the patient and the survivor, as they get ready to, and just start thinking about getting ready to think about my life without my spouse. So distress may still be experienced even though loss and growth, they could both occur. There's emotional waves or like an oscillating fan going back and forth, from what's normal and unexpected. It's never orderly, and there's not a textbook I told you earlier to follow, but people will speak about, sometimes they grow through a loss, but they'll also still have those times where they, seem to fall off the wagon of emotions and get right back to the point, I can't get out of this hole of feeling like, I don't know which way to go. So, oscillation from what's normal and what's expected, where they feel like they're in control of their feelings or they're accepting. And then there's other times when they have no control and I just can't bear, this pain. So it can't be prevented. Grief, it's a normal process and it's necessary. Got to be able to experience grief. Is it grief or is it depression? Well, being able to distinguish between grief and depression, it can be hard. Got to remember, though, that depression is not a normal aspect of dying. It should be carefully assessed and treated if that's the factor. If that's what's showing up, that has to be assessed and treated. Feeling sad associated with grief, that's sadness, but depression is associated with a loss of self-worth. How do you start a dialogue or a conversation to be able to tell the difference between someone that's just sad or depressed? You may consider just asking, hey, are you sad or are you feeling depressed? When we think about culture may also dictate how long a person mourns or how that person should act during this bereavement period or following a death. Outward expressions of loss are sometimes influenced by their own personality and their own life experiences. Got to remember that when we assess spiritual considerations, while it's vital, it can assist in reconciliation for that person, providing them their self-worth, helping them to be able to resolve guilt if they have any feelings of guilt. It can provide, forgiveness. It can set right the relationship that they may have with God or a higher being. Here we see the types of grief. The very first one, of course, is anticipatory grief. That's defined as a grief before a loss. It's sometimes associated at the time of the diagnosis. Examples of some anticipatory grief could be like actual or the fear of potential loss of health or loss of independence, or if I lose a body part, or loss of my financial stability, or just loss of my mental function. So it's that thinking about it before it actually gets there. The acute grief, that starts immediately after the death, and it also includes like that response to being separated from that person, and also it includes a response to the stress that comes with that feeling of loss. During the period of acute grief, that loved one that's left behind may be confused or not even certain about who they are or where they stand in the scheme of things. They may just pull back and not want to participate in just regular day-to-day life activities, or they may be totally shocked. Those are the things that typically happen right after the death of a loved one. Normal grief, that's described as those usual feelings or behaviors or the reaction to a death. Normal grief reactions to a loss can be physical or emotional. They can be cognitive or behavioral. They can be cultural. Active grieving could take years. nobody actually gets over a loss, but the relationship with the deceased, it changes. And then thereby, the bereaved is able to kind of reconnect with the world around them and those that are still alive. Complicated grief, that's seen in about 10 to 20% of those that are bereaved. And it's a little bit higher for those that have lost, actually grieving the death of a child. It's important that we work closely with mental health professionals to make sure that folks that are experiencing complicated grief get the care that they need. I want to talk for just a little bit, kind of dig a little deeper into this complicated grief and kind of go over 4 different types of complicated grief. It's chronic. Chronic grief can be characterized by those normal grief reactions that don't go away and they just keep going. You keep having these feelings for a long time. It can also be called prolonged grief disorder, and it's actually been added to the DSM-4. Excuse me. A delayed grief is the second one. That's usually characterized by that normal grief reaction. They're suppressed or they're pushed down or postponed, and the survivor either consciously or unconsciously just avoids dealing with the pain of the loss, or they just refuse to talk to anybody about how they're feeling or don't want to be a part of a bereavement group. No thanks, I'm fine. Some exaggerated grief, that's that intense reaction that could include, having nightmares or behaviors that are way out of character or delinquent. Some phobias or some, just abnormally fear of things that typically have never bothered them. And of course, being able to have those thoughts of suicide themselves. Mask grief is that 4th type of complicated grief. And what happens with mass grief is that survivor, they're not aware that the behaviors that interfere with normal functioning are the result of that loss. They may get to the point where they start canceling lunches with friends or don't want to go, out on our regular lunch date because they want to go to the cemetery every single day to visit their loved one. When you think about complicated grief, some risk factors, could include like that sudden death or traumatic death, suicide, homicide, dependent relationship with the deceased. So there are lots of things that could be risk factors. Multiple losses. Hadn't really gotten over a loss that previously to this one. Lots of stressors, difficult dying processes like pain and suffering, no support system, no faith system. Studies say that complicated grief is more prevalent in women 60 years or older. So the older adult, some of the factors that will contribute to that complicated grief are, of course, the lack of a support network, losses back to back, not being able to have skills to cope with losses, and then just loneliness. Finally, I'll discuss disenfranchised grief. That's defined as any loss that is not validated or recognized. Society may not want to acknowledge the grief and doesn't know how to deal with the loss. Those people that are affected by this type of grief don't feel free to openly acknowledge or to grieve or to mourn openly. People like that are at risk to disenfranchised grief would be partners that have partners of those that have end-stage HIV, or ex-spouse or ex-partner, fiancés or friends, lovers, a mistress, or even a co-worker. Children experiencing the death of a step-parent. Women that have experienced a terminated pregnancy or a stillbirth. They don't feel able to openly acknowledge their grief and what they're feeling. When we think about a grief assessment, of course, we know that starts immediately at the admission time or the diagnosis. and it should be an ongoing situation to kind of keep feelers out for those complicated grief. Um, it includes the family, uh, the family members, and significant others. It throughout the course of an illness, it should be, like I said, we should do a spot check just to see if the grief is becoming more complicated, because the nurse, the caregiver, even the members of the IDT team that have a care plan with this patient have to remain cognizant and alert the nurse to possible signs, symptoms of complicated grief. It's very important, though, that we always be, to be honest in all aspects of care, right at the time of diagnosis, development of goals. If we're ambiguous, it only makes them, more confused and brings the grief to a higher dimension. Get the help from the social worker, from the chaplain, from others, if they need some questions to ask during this time, or, since you got the news about your illness, how you doing? How you feeling? Are you scared? What's going on in your mind? I want to just share with you really briefly. There's a brief questionnaire that has about 5 questions, and it's based on the scores are 0 to 2, and 0 would mean not at all, 1 would mean somewhat, and of course 2 would be a lot. And it's just 5 simple questions. And so, how much time? These are the questions. How much time are you having trouble accepting the death of your loved one? And of course, they would answer either 0, 1, or 2. How much does your grief interfere with everyday life? How much are you having images or thoughts of your loved one? That last image that you saw them when they died, or other thought about the death that bothers you. How many times is this happening for you? Are there things that you used to do when your loved one was alive that you don't feel like doing anymore, or that you avoid? And then how much are you feeling cut off or distant from people or friends since your loved one died? Even people that you used to be close to, those family or their friends. So, that's just a really brief opportunity to kind of assess that grief situation. When we think about children's grief, we have to base that on those developmental stages in children, and it can be normal and it can be complicated. The symptoms of grief in younger children: nervousness, uncontrollable rages, or getting upset, getting sick, and nightmares, or having hyperactivity, depression, compulsive behavior, memories that are fading in or out, excessive anger. I can share this story with you. My granddaughter, who was 5 at the time that her mother lost her sister, she was 40 days old when she passed away. And my daughter didn't know how to explain, because she spent all 40 days in Le Bonheur Hospital. So it wasn't like she was ever at home, although they had prepared home. But for several weeks after the death, it was like my granddaughter's behaviors got erratic. She would throw temper tantrums. She started wetting the bed. And it almost seemed like she was just going against everything that my daughter had to say. And so she was able to get a child life specialist on board to be able to, and allow her to start voicing some of the things that she was feeling, being able to color and draw out what she was feeling. And of course, this is still a very sensitive area in my daughter and her family's life. However, being able to identify that both her 5-year-old as well as her 10-year-old and even her toddler, she even had a toddler at the time as well, that they were able to express themselves and to grieve according to their ages and stages. So that is very important. When you think about grief in older children, that could be, difficulty concentrating, or being forgetful, or schoolwork just bombs, or insomnia, or sleeping too much, or becoming withdrawn and not being, social, being resistant to discipline. talking or attempting suicide. So lots running away from home, compulsive behavior. So these are just, it's very true, but just keeping in mind that their grief is going to be based on their age and their stage in life. Some grief interventions for survivors. We have an opportunity to provide those grief interventions for survivors. We can provide presence by actively listening, touching, silence, because everybody's got a story. Assist with identifying who their support system is. Is it extended family, friends, or even support groups? To collaborate and refer them over to bereavement specialists or to those bereavement resources. Normalization of the grief process, and also make it individual. It's every single person has their own way of dealing and also of grieving. So let them have their individual process of grieving. And of course, actualize that loss and facilitate them living without the deceased. Because of course, it's the nurse's responsibility to be aware of cultural characteristics of grief and mourning for patients and family members and survivors that they take care of. You know, we continually have to pay attention to those that are bereaved, you know, work with interprofessional colleagues, especially those that are in grief counseling. I have another video here. It's about 12 minutes long. It kind of has a story. There is a story from Johns Hopkins, the only metastatic cancer survivor retreat of its kind. Let's see if I can get this to play for you guys. Oh, sorry. Hold on.
There's some interesting history regarding this particular retreat that we refer to as the Metastatic Couples Retreat. For more than a decade, I've been conducting survivor retreats for women stage 0 to 3, and we've been holding them here at this facility, Bon Secours Spiritual Center, a very relaxing environment, peaceful environment. But I would get emails from women, some I knew, some I did not, saying, when is the retreat for me? I have metastatic disease.
When I'd throw my little pity party or whatever at the beginning, you know, and I had that moment of, why is this happening to me? You know, why does this have to happen to me? I'm young, I have 2 young kids, why do I have to be the one going through this? And his response was, it's not happening to you, it's happening to us.
What are the biggest things that they're worrying about as they continue to travel forward, recognizing that eventually they will die of this disease?
I think I was in denial that it can't just be cured and be over with. And I know it's a long road ahead.
I think that's both our best way of coping with things is through humor, which really throws the doctors off and the nurses and our friends, and you know, because yeah, a lot of them say the same thing, like, you're always happy, you're always smiling, everything looks great, you know, you look like you just lost a bet and shaved your head.
Some of the activities that we provide for these couples is an opportunity for them to candidly speak with others in the same situation they have. So we actually break the couples apart. We will have women only in one room, men only in another room. I think that the men only is one of the most powerful things that we do at this event. Men are thirsty to find other men in the same situation. There is a sense of relief when they hear a husband say, "This is how I've been dealing with this. I get in my car and I scream and cry and curse." And to find out that all of them get in their car and scream and cry and curse, that they're not alone.
You never do fully recover. There's always the new normal, and then they start coming at a faster pace. So as time goes on, it's taking away another chunk of the life you had together and of what your wife used to be able to do.
It's harder and harder to see a positive future.
And then in bringing them together, it's who feels comfortable in talking about any of those candid discussions that took place in the men's only and women's only room. And one by one, people around the room do speak up and do share.
We talked in our group about the loss of hair being, something that people lose their public face, but I've lost my public face and body, and who is that person? I don't recognize her.
Well, I know it's inevitable, but it's hard to believe that I actually have it in my bones right now because I feel so good.
Right now, I feel like I'm responding to treatment so well that it's almost miraculous.
I don't want them to feel like I gave up. You know what I'm saying? I want them to always think that no matter what, I fought for them.
I'd say that my biggest fear is for my husband, because, at the end of it all, I'll be dead. That'll be easy. It's like going to sleep, I guess. I don't know.
We have provided information about how decisions are made and that physicians are not God, but also that physicians are hesitant to speak up and really give a time frame, even when in some cases they do know the time frame. Just as I have mentioned, I can see how ill some of these women are, and I can guesstimate how much longer they're going to be here.
I am bedridden for most of the day because of my pain and because of a great deal of fatigue, and I don't know how close I am to the end.
It's hard to face your own mortality.
The hardest part for me, I think, is probably the kids. I have a 2-year-old and a 3-year-old. They were 1 and 2 when I first got diagnosed. And just not knowing if I'm going to be around to see them grow up, not knowing if I'm going to be around to even see them in kindergarten, not knowing if they're going to remember who their mom is at the end of all this. That to me is hard. I don't want them to forget me.
One of the things that we did in the women's only group was that I talked about women considering getting cards for their children, going to the store, asking to meet with the store manager of their card store and say, "I'm going to succumb to this disease and I need your help. I want to select birthday cards for my children up through age, usually 21. When my child goes to communion for the first time, I want to have a card for that. When they get married, when they have their first child." And writing in those cards, what do you want to tell your child on that day, is a very powerful way to still be here instilling your values in your children. We also have some other sessions looking at some private moments, having massage, having Reiki therapy. We also play the Almost Newlywed game, which is a lot of fun. We're also going to be out on the labyrinth today. They have a beautiful stone labyrinth here. One of the interesting things when we do this for couples, we send the wives in first and then wait a few minutes and then send the husbands in. And at some point on the path, and it's a very specific walking path that you do, the husband and wife will meet. And how they interact with one another, whether they just brush by whether they stop and hold one another, whether they stop and sob with one another, to me is a very strong symbolization of their love for one another. We also will have this afternoon the creation of memory ships. And what this entails is each of the patients will be given a vase in the shape of a hurricane lamp, and it has blue and green sea glass mounted all over the outside. The base is white with sand, and then embedded into that sand are seashells. They will be given a journal, a pink journal, and stones, pebbles, smaller rocks, seashells, and sea glass for them to use today as well as to take home a supply of. And I will ask each of them to go back in time, as far back as they can remember, what was their first happy memory. I want them to record that in the journal and then select one of these objects to then go in this vase, which I tell them represents them. This vessel is a symbolization of them and their lives. Our memories are something we hold on to. We take them with us. We also leave them behind, and it's a very powerful connection.
It's nice to have people that get it. You know, they understand what you're going through. They understand, even though it's not the exact same stage or the exact same disease.
It makes me happy to be able to talk about this because it's so wonderful that this is offered to people going through things like this. I mean, I wish it was more more spread and closer to home and all that other stuff, but it'll spread, you know, from all of us.
I'll be talking to them about the fact that they've all been in shark-infested waters. They come to Johns Hopkins or to their cancer center, which is a safe harbor, so we get them stabilized so they can set out to more ports of call. But that one day they will do a final sail that they must do alone. I will then give them on parchment paper a verse written by Henry Van Dyke. I always paraphrase that verse for them. And the verse goes like this. He talks about a family standing here on this shore, and they're at a dock and they see this huge, magnificent white ship in a dock, and they're watching as her cargo is getting loaded on, and they're really admiring her size and her grace. Cargo is done, the sails go up, the wind snaps the sails, and she sets out of the port out into the ocean. And they admire her even more in seeing her now so gracefully. She is going out further and further out into the water. And they watch her as she's going out all the way to the horizon line. And she gets smaller and smaller and smaller until then when someone says, she's gone. But gone where? She's only gone from our sight. She's just as large in mast and hull as she was when she was at our side, and just as able to carry her living freight to her new and final destination. Her size is diminished in us, but not in her. And as we stand here as family and friends and say, there she's gone, there's family and friends on the other shore sending up the glad shout, look, here she comes. It's a very powerful way to discuss death and to see death in a more peaceful manner. Every single husband who has attended these retreats has used that analogy and will call me and say, we found out today that her sails are up, or we found out that she's getting close to the horizon line. And then they will call me again and say, she's reached the other shore and what time, and who he believes was there waiting for her. And until we have a true prevention for this disease, I want to make sure these women are not forgotten survivors.
It's a very impactful video. Start thinking about some interventions for the children and parents or even grandparents of just keep in mind that interventions, they're important. Doesn't matter what the age of the survivor is. Children that have lost a parent, a sibling or grandparent, their grief has to be assessed depending on their developmental stage. I've talked about that before. They may be limited in their ability to talk about and to describe their feelings of grief. For those parents, the death of a child has been described by some as the most devastating experience. The death may not only affect the parents, but the siblings and grandparents, other relatives, friends. That's for those survivors. Emotional and spiritual practical needs for support happen even beyond that child's death. For grandparents, grief can be twofold because they're not only experiencing their own grief, they're witnessing the grief of their child or the parent of that child. So we have to be cognizant of that and refer to support groups as much as possible. Of course, grief support should be provided in a variety of ways. One thing I want to pause and give way to, and that is encouraging grief that's normal. Sometimes give folks comfort, but then also we can't tell anybody how to grieve. Have to keep that in mind. So when we talk about grief support, it could be online, it could be bibliotherapy, individually or in a group or a community support, and even by utilizing rituals. Online support has really taken off over the last few years. It's helpful because they usually can get immediate attention. Once they post something, they get a response pretty quick. Individual counseling or group support, community support, those can also be important to just individual people. Just keep in mind that there are many variety of support systems. Thinking about completing the grieving. See if I can get back in here, guys. Sorry about that. I didn't know if you all could see that or not. There we go. Sorry, guys. Give me a second. Have a technical moment here. All right. Sorry about that. Of course, grief work is never finished. There'll always be time that a memory or object or anniversary or just feelings of loss happen. Grief can diminish and healing can happen. And a lot of times you see that when the pain of the loss becomes less or the survivor has adapted to life without the deceased, or the survivor has physically or psychologically and sometimes socially let go. Of course, letting go is hard. It's a process. Can let go and still love, can find that uniqueness and some secure, true meaning in a relationship that they had with the person that died. Memories, of course, should always be cherished. I think that Lois Tonkin here proposed a theory that grief doesn't decrease, but rather we grow. So grief doesn't get smaller, but we just grow around that grief. I have a case study here. Susan is 54 years old, caregiver to her partner, Tom, who's 72. They've lived together for 6 years. Tom was diagnosed with ALS 2 years ago. His disease is moving pretty quickly, and he's just gotten back home after 4 weeks. He's now on the ventilator. Susan is exhausted. She can't eat or sleep. They have little community or family support. I'm just going to ask, if you were that nurse taking care of Tom, you're taking care of Tom, but Susan's got some needs there too. How would you assess those needs? And basic things like sleep and food. I'm just giving you food for thought here. You guys can unmute and speak if you want to. You don't necessarily have to, but I just want to make sure that these are some things that we are typically thinking about. And then, are there other members of the interprofessional team that could help? And if there are, who would help? Just something to think about. I won't belay your time. I've got about 15 minutes and I want to be able to at least get through my slide deck here. But that's just something to think about, because not only is the patient have needs, the caregiver has some very, very apparent needs here. Going the wrong way here. There we go. When we talk about cumulative loss, it's a succession of losses that experienced by the nurses or staff that work with patients with life-threatening or serious illnesses, usually on a daily basis. And of course, some cumulative loss that we can all say that we've experienced, and that's those healthcare professionals that were around during COVID. We experienced quite a bit of loss, and they were compounded. During the COVID pandemic, there were nearly 1 million healthcare personnel that were infected with, and 2,300 of those died from COVID. So, even though there were interventions designed to control the pandemic, quarantine and limitations, there was a lot to hopefully put in place to where we were able to try to get in front of that feeling of just being of cumulative loss, just constantly losing. If I could switch gears a little bit and talk about some moral injury. Moral distress, compassion fatigue equals burnout. Moral injury, of course, is that distressing psychological, behavioral, or social, and even sometimes it's spiritual aftermath after a lot of events, traumatic events. A moral injury can happen in response to seeing behaviors that go against the individual's values and their moral beliefs. And of course, that leaves us feeling guilty, shame, disgust, and anger. That's some of the most seen responses to reactions of moral injury. That moral distress, that happens when we know the correct way ethically that this should go, but feel like we're powerless. We can't do anything to fix it. I guess an example would be when we know what to do, the right thing to do, but because of the institution that we work for, or there are constraints that make it almost impossible for us to do that. That is definitely some moral distress. Compassion fatigue, of course, that's a syndrome, and that happens when we're constantly exposed to the stress of working with health issues or death and dying and suffering. Believe it or not, it can actually lead a person to being unable to love, to nurture, to take care of, or to empathize with somebody's suffering. leading to burnout. Of course, that's the bottom of that funnel you'll see there. That's a broad-based syndrome that develops gradually as a person interacts within the conditions, those time pressures or stressors of a workplace. It's associated with a situation rather than an individual. Of course, this can happen to us and it show itself physically, psychologically, loss of motivation, emotional, become cynical and inefficient. Some factors that are associated with burnout, of course, some societal and cultural factors to consider would be the politicalization of science and public health, structural racism, health inequities, misinformation about health, and some unrealistic health expectations of like the healthcare workers. Within the healthcare system, that burdensome just paperwork and tech, the poor care coordination, misaligned regulations and reimbursement, all contribute to a healthcare worker being burnt out. When we think about from an organizational standpoint, variables such as not having leadership, an excessive workload, a disconnect between those values and key decisions, those all contribute to an organizational contributors to burnout. Of course, that workplace and learning environment, when there's not any flexibility or any autonomy or having a voice, gives us a feeling of just being powerless. A lack of collaboration along with just enough time with patients and colleagues, that makes a really negative work environment. Touch briefly on the idea of bullying. Of course, we've all witnessed some type of bullying at some point in our life. It can take on many forms, experiencing behavior that's not welcome, offensive or unsolicited, or even objectionable. It can be physical, psychological, or verbal. And of course, here you see it's repeated, unwanted, harmful actions. Their intent is to humiliate, offend, and to cause distress. This contributes to a poor work environment, lower patient satisfaction scores, the increase to patients to have poor outcomes, nurse turnover, which leads, of course, to more costs. So it's an awful cycle. So being proactive when we take care of ourselves. Some questions to consider when we, stopping and paying attention to the warning signs of compassion, fatigue, or burnout. How does my behavior change? How do I communicate any differently? What distractive habits am I tempted by? And how do I project my inner pain onto others? Because as I become self-aware, I can be more successful in self-care or taking care of myself. So some elements of self-care are listed here. That's self-reflection or examining expectations for a positive outcome. And we should be non-judgmental and show compassion. Self-efficacy, that's the positive. Self-efficacy is our knowledge that I'm capable, believe in myself. It's hard to do, but it's very important when we want to talk about self-care. When we talk about, body monitoring, that's getting in front of and managing the chronic illnesses that we may have. Regularly assessing, bodily processes through, redirection of attention to ourselves. Doing pulse checks and making sure that we're checking in how we feel, because we have to listen to our body's voice in order to achieve overall well-being. And of course, having that well-being planning or having a wellness plan, writing down some plans, some things that will help me to increase, that will be accomplished. That's how we kind of look at being able to be self-aware and to self-care. Of course, being able to be in this arena, taking care of folks palliatively and with hospice and long-term or life-changing illnesses, it takes emotional labor to accomplish the goals. This takes a lot of energy, a lot of resources. When we overuse personal energy and resources and don't take time to re-up on our rest or renewal plan, it can lead us to be stressed out, emotionally exhausted, cynical, and inefficient in our work. And these are things that we have to be aware of, because when we have balance, or when we're balanced in our life, it helps us to be self-efficient, to remain optimistic even in the worst times. It helps our hardiness, and it definitely improves our resilience. I remember an elder in my family used to say, what doesn't kill us makes us stronger. And I have lived that and know that to be a very true statement. We think about being able to adapt, a lot of factors that influence the ability to adapt, or the process to adapt. That would be, professional education, personal death history, past experiences with death on a personal level. Maybe some unrelieved grief issues can influence the professional's ability, or your ability to cope with caring or taking care of dying patients and their family. Life changes, of course, that could include a death in your own family, or loved ones, or things like that. Certain things in life have to sometimes weigh in on our ability to adapt or to bounce back. And of course, whether or not we have the presence or absence of a support system can also influence the ability to get through the stages of being able to adapt. Lastly, I'm just about at the end of my PowerPoint presentation here, but taking care of yourself, it's unique for you. It's whatever it takes for you to take care of you, whether it be laughing or journaling or dancing or music, or whatever it takes for you. And then please keep in mind that being able to balance and holistic care, role model good self-care for you, role model that for those that we work around, because if we can't take care of others, if we cannot take care of ourselves, that's just thought to live by, basically. And finally, our care doesn't end with the death of a patient. Have to be able to recognize and respond to how we grieve, or the fact that we may be grieving because of the processes of our jobs. When is a time to push back and take a moment and self-reflect and rebuild, and to process what we're feeling? Bereavement care is interpersonal. Chaplains, social workers, nurses, this goes across the horizon. We have to be able to work together to provide sound bereavement care. And it's, this PowerPoint says nurses, but I have to say, across the line, everyone on the IDT team, or, everyone that's dealing with serious illness, has to role model excellent care. I'll stop sharing right there. I don't know. I see I may have missed a question or two, but if you guys want to take these next 5 minutes and unmute and answer or ask any questions that you may have, or provide any feedback, I'm going to take a quick look at the screen here and see who I have here today. Any questions? Well, if you guys don't have any questions for me, I know it was a lot of information to process. Please keep in mind that you guys will receive the link, if you'd like it, for some of the resources that have been provided. Also, if someone that has missed this session, and just know that to those that have been registered for this session has the ability to be able to take a look at it on YouTube. If you are still in need of a session, please send me an email that you may have missed. I know that there is a group that still needs to have the first session. And actually what I'm going to do is just record that verbally and just send that out to anyone that may need that. I agree, Amy, that video was very good. I had to go get Kleenex, but I think that it was very, very, very important. Really good and inclusive webinar. Thank you. I don't have anything else unless you guys do. I will see you next week for our final module in ELNEC, and it's going to be final hours, and I think it will be 1 hour. So I will see you guys next week at 12 o'clock. Thank you so much for all that you do. Have a great day.